Very good evening to all of you. Welcome you all for the fourth session of the movement disorder SIG. Today we have another important guest lecture on functional movement disorders by Dr. Biju Ami. I request our President Dr. Shivali Gulati ma'am to introduce the speaker for today's session, the experts and the moderator for today's session. Over to you.
Thanks, Mahesh. So we have Dr. Biju Hamid, who will be talking about functional movement disorders, which I think is very, very important. And everybody knows him. I call him synonymous to ICNA. And basically, his area of interest is movement disorders, neurorehabilitation, cerebral palsy, and all. And he's been heading the neuro rehab in Gosh, and currently he's establishing pediatric neuroscience in the UAE. And now we have experts, as we in our preceding sessions, we have experts from diverse resource settings, and pediatric and adult neurologists in combination. So we have Dr. Taj, who has been kind enough to be there in the fourth consecutive time on this session, and I am requesting him to be there for the next one also, which will be interesting cases. His passion is movement disorders, and he's working in Malaysia. And in addition, we have Dr. Hassan. Dr. Hassan, who is a very renowned pediatric neurologist from Turkey, and he heads the Turkish Pediatric Neurology Association, and as an amazing professional. In addition, we have two adult neurologists with a lot of interest and experience in movement disorders, Dr. Charulata Shankla, who is a consultant neurophysician in PD Hinduja Hospital, Mumbai, and a very well acclaimed adult neurologist. And in addition, we also have Dr. Sanjay Pandey, who is professor and head Department of Neurology and Stroke Medicine at Amrita Institute of Medical Sciences, Faridabad. And he has also worked so much in the movement disorders. Thank you all for joining. And the moderator of the session is our alumnus, the dynamic and younger and younger by the day, Dr. Rachna Dubey, who is a pediatric neurologist working in Medanta Hospital, Indore, MP. Before I hand over to Rachna for conducting the talk, the discussion, because we'll have a talk followed by discussion between the experts and the Q&A, I'll request Sangeeta, can you just show the, Asmita, can you please show the conference slide? Sangeeta, to talk about the upcoming conference on 8th, 9th, and 10th, which is the annual conference of our Association of Child Neurology India in CMC Vellore. Dr. Sangeeta.
Thank you, ma'am. Good evening, everyone. On the behalf of organizing committee and AOCN team, I would like to extend a warm invitation to all to attend the Child Neurocon 2024, the 14th annual conference of Association of Child Neurology India, which is going to be held at Vellore this time from 8th to 10th February. A gentle reminder to everyone to register for the conference at the earliest. The early bird registration is open till 31st January. We have an interesting academic program in the pre-conference workshops and the conference days. The academic schedule includes topics covering up all subspecialties of child neurology and enriching talks by the international and the national faculty. The full scientific program has already been uploaded on the website, Child Neurocon 2024. As we have only few slots available for registration for the pre-conference workshop, please register at the earliest. We have posters and platform presentations on 9th and 10th of February. We'll be soon sending the communication regarding the guidelines for presentation. On 9th evening, we'll be having a wonderful cultural program as well as a banquet dinner. And also a gentle reminder for the trainees to register for the preliminary rounds of which will be held on 9th, followed by the final round on 10th of February. And we have exciting prizes for the quiz winners. So we are looking forward to meeting you all at Vellore soon. Thank you.
Thank you. Rachna, all yours.
Thank you, ma'am. And we are on fourth session of this movement disorder SIG, and I'm sure, it cannot be more interesting than this. The topic today being functional movement disorder. I would not be hindering much between the session and the two sessions. So over to Dr. Biju Hamid. Sir, please carry on.
Thanks, Rachna. And thanks, Dr. Shivali, for the opportunity. And it's so nice to see experts like Dr. Sanjay and Dr. Charulata, along with my colleagues, Taj and Dr. Hassan. So as I had wished, I think rather than a didactic lecture on functional movement disorders in children, I hope we could make this more informal, and at the same time try and see how we can improve the situation in terms of children suffering from functional neurological disorders, taking important points and suggestions from our adult colleagues who are more well versed in this area, and particularly an area where a huge amount of progress has been made. I again stress, like, huge amount of progress has been made in the adult context, and there are huge unmet needs when it comes to children. And I hope this special interest group session would meet go some way in terms of addressing those needs. Okay, so functional movement disorders. Now, the points that we would address in today's talk would be the terminology, the approach to assessment, management, the role of physiotherapy, a little bit about the pathophysiology, and how the paradigm has shifted and how we can keep up the momentum. So this is a very famous picture which we all have seen, the famous painting of Charcot demonstrating a case of hysteria at the Salpêtrière Hospital in Paris in 1887. So this was the neurology grand round, and this was the time when psychology and psychiatry was at its forefront. So early leaders in neuroscience, even from then onwards, were very interested in functional neurological disease. But probably the best thing that has happened in neuroscience in the 20th century was the neurology and psychiatry broke ranks and grew apart, and each one flourishing in their own. So that's how functional neurological disorder became a condition in the borderland between neurology and psychiatry. And that's why the ever interesting discussion on should this be managed by neurologists or should this be managed by psychiatrists. But like I said, in the last 20 years, there's been a renaissance. And this is because people realized that functional neurological disorders is common and can be identified not just by excluding an organic disorder, but by identified by ruling in a diagnosis. And at the same time, advancement in neuroimaging and psychology and also using other scientific tools, electrophysiology, etc., to connect the brain structure and function has improved the biopsychosocial framework for thinking about functional neurological disorders. So hence the importance of discussing functional neurological disorders from a neurologist's perspective today. So this is the DSM-5 diagnostic criteria, and that has been a major change from the DSM-4 when it comes to diagnosing functional neurological symptoms. So in the DSM-5, it's called conversion disorder, also termed as functional neurological symptom disorder. And the criteria includes the key diagnostic features of inconsistency and incongruity on examination, emphasizing the positive neurological features. And the key important thing was the identifying an underlying psychological trauma has been relegated to just a discussion note and has been removed in the DSM-5 as a criterion. So inconsistency refers to changes in the manifestation over time, such as for example, if it's in case of tremor, it would be a variation in tremor frequency and amplitude, or remissions and exacerbations. While incongruity will refer to the discordance with the other known neurological disorders, or incongruence with the human anatomy or human physiology. And in addition, there are also additional general diagnostic features like distractibility, suggestibility, etc. So that's the key difference, is the association with the psychological stressor has been removed, and also it's no longer needed to exclude malingering or feigning in order to make the diagnosis. So approach to assessment. Now, and this is somewhere like, some colleagues might, it's very important, particularly for trainees in pediatric neurology, to understand. Of course, as in any condition, when you are faced with a child presenting with a symptom, obviously you focus on the symptom, and the symptom could be normal movement symptom, could be something like dystonia, something like tremor, a tic, and you focus on the symptom. But it is also important that when you then go on to the past medical history, to expand your history to go into the psychosocial history as well. Often I've seen, even in busy practices, where the symptoms are elaborated, and often the diagnosis is made straight away. But then there isn't much time spent on the psychosocial history, which might then come to light only much later. Perhaps, like, even from personal experience, in some situations, some of the psychosocial history had only become evident on the day of discharge, when it was then too late to address it, and just prolongs the hospital stay and management for the child. So it's very important to recognize that along with the history, the psychosocial history is very important. And then, of course, then you turn on to the physical examination, you formulate the diagnosis, and you deliver the diagnosis. And we'll come to those aspects later in the course of the talk. So the main functional movement disorders, as we know: tremor in children, tremor, dystonia, sometimes jerks and myoclonus, functional gait, and tics. So there has been loads of publications explaining the different functional movement disorders in children, and what are the clinical characteristics of the functional movement disorder. And as we know, the variability and the high degree of variability is a very key feature when it comes to these symptoms. And in case of tremor, the distractibility is very important, and the variability in the tremor frequency. And then the dystonia, another key feature is the rapid explosive onset. And again, the distractibility, the lack of the sensory tricks. And then functional myoclonus, again, fully suppressible, variability in the duration or distribution of the jerks. Functional gait, where there is a fluctuation. Again, where there is improvement with distraction, worsening with suggestion. So these are all important features that we know, and it's been well published, and which we use in our day-to-day practice to make a diagnosis of a functional movement disorder. And another important feature is, in case of functional movement disorders in children, the dominant side is more affected, and the dystonia may not always be a fixed one, unlike in the adult population. But jerks and myoclonus are relatively myoclonus is relatively more common. But although in our practice, it's mostly it is in the realm of functional neurological disorders, or pseudo seizures, or paroxysmal non-epileptic syndromes. But in children, the distractibility, the variability, the suggestibility, and entrainment are very easily demonstrable. And the variability and the distractibility shouldn't be mistaken for malingering or feigning as well. And as we mentioned, the need to exclude feigning from the diagnostic criteria. And excluding feigning is incredibly difficult anyway, but now it has been removed from the criteria. Now, the value of positive signs, clinical signs. So the diagnosis of functional movement disorder is no longer a diagnosis of exclusion. We rule in the diagnosis, and we need most of these signs which we commonly use, particularly our adult colleagues use in terms of motor symptoms, which includes weakness, the Hoover sign, which has got nearly 100% specificity, both the Hoover sign and the abductor sign, to test for functional weakness. So these are all the list of, this is an excellent review of the positive clinical signs, and in this review there's a whole lot of signs illustrated, so it's an excellent paper to go back and refer. So the entrainment test, which we all quite familiar with, were what we are looking for is the frequency of the tremor shifts to match the frequency of the tapping. So this is the test, and this is very commonly very easy to elicit in children as well. And these are all published videos. So what we're looking for is the shifting of the tremor to match the frequency of the tapping. The frequency and the rhythmicity of the tremor changes. So a very useful test in the clinical setting to diagnose functional tremor. And the Hoover test also, we all know, so it's a weakness of the hip extension, which returns to normal with contralateral hip flexion against resistance. And very easy to demonstrate in a seated position than in a lying down position. And the Hoover sign has got, and the Hoover sign has got nearly 100% specificity. So, so these videos are published videos, and I think it is from Dr. Pante and colleagues. And this is subsequent to treatment where the tremor has completely resolved. Interestingly, in the publication, the authors mention it as following counseling, the movement disorder had improved, and it would be I'd be interested to hear from Dr. Pante about the role of counseling in functional neurological disorders. So this is a demonstration of the functional gait, where the balance is extremely maintained when you do tandem walking. So this is an example of the myoclonic jerks. Again, the authors note that like following treatment, it had improved. But this is when he is called, when he's asked to do something, he gets a and this is a functional kick. You can see the elevation of the right, the left shoulder. It's a severe retro callus. So this was a nice publication of a whole spectrum of the movement disorders, and I think it was around 58 children from India, which included both adults and children. But the authors note that following counseling, the all of them had made a good recovery. But the important thing is, although tremor and dystonia are quite common in the pediatric population, it does not always need to be functional, as in this case in this child on the right. So this boy on the right with the tremor had a complex regional pain syndrome following an injury to the hand. Which is why also during your assessment and history, it's very important to also ask for symptoms like pain and fatigue, particularly in the teenage group of children, because symptoms like chronic fatigue and pain have got huge relationship in terms of like the prognostic findings in this group. So again, these are more examples of generalized tremor, again with frequency variability. Dystonic postures of the trunk. So along with the positive signs on examination and the distractibility and the variability, the buckling of the knees, it's a very characteristic finding that we may notice in the gait. And interestingly, even in retrospective case series, if you look at the diagnosis rate and if you look at the rate of misdiagnosis, and it is quite low in terms of misdiagnosis of a functional disorder. So which means that it is pretty easy if you go by the ruling signs and if you do a proper examination, it's always easy to make a diagnosis of a functional movement disorder. But the difficulty comes when there is an overlap of organic problems along with the functional problems, as you would, for example, in when pseudo seizures or non-epileptic attacks and epileptic attacks overlap, or when dystonia, where the functional dystonia and the organic dystonia overlap, or a functional tremor and an organic tremor overlap, and that is where the diagnosis becomes tricky. And neurophysiological tests can also be used to help, particularly in these myoclonus, etc. But again, these are more relevant for the adult population, and we know that the pre-movement potentials that you see prior to the jerk with maximal amplitude in the central cortical areas, the red shaft potentials, which indicates functional jerk, which also can sometimes be seen in tics, according to this paper. So, but the role of neurophysiologic testing in children with functional movement disorders is very low, at least in our practice. Other than, of course, when we use video EEG for diagnosing paroxysmal non-epileptic attacks. So when the clinical clues are pretty relevant, and it's very useful to differentiate between the functional disorders in children, particularly tics, myoclonus, and the paroxysmal dyskinesias. But again, clinically, the most important is the inconsistency and the rhythmic nature and the precipitating physical events. But again, it's not very useful in a pediatric setting, and also with the myoclonus and paroxysmal dyskinesias, you tend to get the positive family history. In this paper, they indicate that the childhood onset is less in functional jerks, but again, that's not something which we see in our practice, because the tics and the myoclonus tend to be seen in children as well. Now, again, the dystonias are also quite important in the pediatric population, and so this is a girl who is 12, and she had presented with. So initially, she had presented with a gait which, on examination, was very suggestive of functional gait, and then she developed this abnormal movements of her tongue, which I suppose it would be, you could call it lingual dystonia, and it was quite task-induced by speaking, and also was quite characterized by protrusion, and there was no clinical suggestion of any involvement of other body sites like the larynx or so lingual protrusion dystonia, you might argue as a differential, but of course, in terms of the clinical context, along with Russell examination, this was a functional dystonia. So this is another patient of mine who had a functional neurological disorder for several years, and unfortunately she didn't make much improvement, and she was relegated to a wheelchair. Obviously, she was happy in terms of her quality of life, and then she went on to become a hairdresser, but so in terms of dystonia, the classic functional dystonia phenotypes, as we know, are the functional hand dystonia, with preserved pincer function. The post-traumatic painful torticollis with a fixed lateral collis. You can see the ipsilateral shoulder elevation and contralateral shoulder depression. The foot dystonia with a fixed foot plantar flexion and inversion, and the facial dystonia with the unilateral tonic jaw and lip deviation with involvement of the platysma on the same side. So this is again a classical functional dystonia posture. So how do you differentiate between the organic dystonias and the functional dystonias? Now, obviously, a sudden dystonia, which is quite explosive in onset, evolving within few days, would point towards a functional dystonia. A rapid progression to a maximum severity with paroxysms and remissions, the disability disproportionate to the extent of dystonia is an important finding. And also, you often get to see other associated features like functional limb weakness, sometimes sensory disturbances, etc., in case of functional dystonia. And people have tried botulinum toxin in functional dystonias, and sometimes some others have indicated a placebo response, but usually it is poor response, as one would imagine. While organic dystonia, we all know how the onset is and how the progression of the condition is. But it's very important to differentiate between the organic dystonias and the functional dystonias. Like, for example, the lingual dystonias that we saw and tongue protrusion, for example, associated with feeding dystonias is frequently seen in degenerative diseases, as we know, particularly in conditions like Wilson's, etc., or even more disabling conditions like Leishman, etc. So it's important to differentiate between the organic dystonias and the functional dystonias. Now, functional gait is also very common in the pediatric age group. So the swaying gait, and often in a psychogenic gait, there's always hemiparetic, paraparetic, ataxic gait. But also there will be a fluctuation of the impairment, sometimes an excessive slowness of the movements, hesitation. And as we can see, most of the postures are uneconomic, with waste of energy. And as we saw in the previous video, the sudden buckling is also, sudden buckling with or without falls, are all important features of functional gait. But sometimes you can see functional gait in association with organic conditions as well. This was a published video of a child with Coffin-Lorey syndrome who had a bizarre gait, which was a functional. Obviously, she had other conditions as well when she had seizures. She had this dystonic posture, which is deemed to be a functional movement disorder. obviously she had other problems. She had seizures. So this was on hearing and sound. So and she, I mean, after treatment, her gait had returned to normal. So clearly, in the beginning, what she had was a functional gait. So it's important to also note that, like, sometimes these things can overlap, making things complicated. Tics, as we know, are very common, both functional tics and the organic tics. So this young man on our left is ticking away. And he was quite resistant to treatment as well. I mean, he had a tic disorder, subsequently diagnosed with Tourette's. So this girl had continuous tics, except when she was asleep, almost continuous. And when she had presented, she had been ticking on for. But that was so so this girl on the right, so it's a functional tic, while and you might have all heard about, during the COVID-19 pandemic, we all saw in our practices a huge increase in the number of children with tics coming in. And you must have heard about this. There was an increase in new cases of functional movement disorder that into which children began experiencing sudden tic-like movements and sounds like vocal phonic tics as well as motor tics while they were watching similar occurrences on social media. And it was all, so this was a published video series from 6 children who were all influenced by the same person on TikTok, who was then demonstrating lots of motor tics and social tics. And because due to its alliterative nature, it was called TikTok tics. So this was when the examiner was whistling. So what we are actually seeing here is what we call modeling. Or modeling is the act of imitating certain symptoms, act of imitating certain motor patterns by observing others who have a similar indicator. So, and there's plenty of evidence to suggest that, if you're exposed to specific movement patterns, it might unconsciously inspire you to emulate those movements. But unlike other types of movement disorders like tremor, tics, tics has got that unique attribute of being constantly more predictable. The consistency in which the tics are modeled is probably the reason why sometimes it's very difficult to differentiate between functional tics and that in Tourette syndrome, because the consistency in the emulating behavior which they have observed is very good. And these two girls have, and along with the other 4 children who are published, they all have been influenced by the same TikTok person who has been posting these videos on TikTok. So, I mean, during the COVID-19, like obviously we saw lots of children with these tics, and there has been some proposed models on why this might have happened. In the context of predisposing traits with experiencing precipitating factors. So if you have a precipitating factor like a psychosocial stressor, which is like social isolation, online schooling, physical stressors, then the stage is set for a functional disorder. And then in that situation, when you are then exposed to an external stimuli, like for example, the social media, and also if there's a social reinforcement via social media, it will reinforce the specific behavior via unconscious reward mechanisms, and that are dependent on the intensity of the external stimuli. And then there is a positive feedback loop of that reinforcement of that behavior. So this has been the proposed conceptual model that summarized the factors that led to the pandemic. So you already have a predisposing factor, and then on top of that, then if you are exposed to the stimuli, the feedback then further reinforces it. And then also, obviously, you can look at the overlap between the functional tics and the Tourette syndrome, and particularly the anxiety and the suppressibility, the difficulties with attention, reinforcement learning, those are all overlap. So in clinical practice, sometimes particularly in children with functional movement disorders, it can be quite difficult to differentiate between the functional tics and the Tourette's, given that like there is plenty of overlap between the two. And this Venn diagram indicates exactly that, the overlapping of the various risk factors, the clinical features, the pathophysiology, and also treatment. Obviously, cognitive behavioral therapy would work for both, and also alongside cognitive behavioral therapy. Even in functional tics, we sometimes tend to use pharmacological agents for comorbid anxiety, depression, etc. So the biopsychosocial model is hence very, very important, and hence the reason why I said in the beginning that psychosocial history is equally important, like the physical, the past medical histories. So the predisposing vulnerabilities, the precipitating mechanisms, and the factors that are perpetuating has to be addressed. So the biological, the psychological, and the social issues are equally important. And the treatment phases are: you address the symptom, you deliver the diagnosis, then you engage with the patient, then the acute treatment comes, and then the long-term follow-up. And in terms of the acute treatment, it has to be in parallel. The medication for any comorbidities, the psychotherapy, and the physical therapy. So how do you then deliver the diagnosis? And that's very, very important. Now, this is somewhere perhaps at the end we might discuss this. So personally, our approach in our institute is that you deliver it upfront. So you discuss, so you explain, and we always use the term functional neurological disorder. And sometimes we deliver the good news, and we often say that not to worry, things would improve. and we tell upfront what is happening, and we tell them why the diagnosis was made, and we sometimes show them YouTube videos of the different signs, like for example the Hoover test, for example, and we explain to them, so these are the reasons why the diagnosis is made. And we have to then make sure that the child, if it's an older child, and the family buys into that, because delivering the diagnosis and getting the child to understand the diagnosis is the first step of treatment, but it's not treatment itself. It facilitates whatever you do after that. And that's very important. And it's important because if you don't manage to get that buy-in, if they don't agree with the diagnosis, or if there is any other suspicion that either suspicion which is imparted to the child, to the parents by the physician, that this could be something else, we need to do certain other test, then the chances are that if you then go straight into psychotherapy or physical therapy, it won't work. It's very important that the diagnosis is understood by the child and the family, and we have to have that buy-in and the engagement. Only then the physical therapy and psychotherapy will work. And in that context, this consensus recommendation is very, very important. The importance of physiotherapy for functional movement disorders. And it's important because it's not like the standard physiotherapy that we all know, like for example, in terms of rehabilitation of a child with a motor disorder. It's a limited hands-on approach. And what it does is not like focusing on muscle strength training. It actually leverages the distraction, and the focus is on completing a task. So very different from the kind of basic physical therapy that you do. And it's fundamentally different principles. It's distraction and tasks based. And the physiotherapist needs to know that they are using different principles of physical therapy for the treatment to work in a functional disorder. And there are lots of guidelines available online regarding this. So which is why it's very important that you have to have a physiotherapist in your team who is experienced in looking after children with functional movement disorders. It's very, very important. That multidisciplinary team has to be set quite early on, and in order to address functional movement disorders. And if at all possible, you should avoid the use of adaptive equipment and mobility aids. Although these are not always contraindicated, there are some situations where we may use, and also include the child in the management. And if there is any maladaptive posture, you always try to minimize that reinforcement. So the focus should be on completing a task, be it like being able to dress, or being able to take the stairs, or whatever the task might be. And it should be very limited. It should be just facilitating rather than supporting the child to move. Very important. Similarly, occupational therapy also consensus recommendations have been made. It's very important. And there is a role for sensory processing assessments and sensory modulation retraining, because many of these patients often do say that the high sensitivity to loud noise, pain triggers, etc., which then exacerbates their functional symptoms. So these techniques, the sensory processing and sensory modulation retraining, are very helpful in it comes to functional disorders. The CBT model works. We know that there are several published literature which shows that the cognitive behavioral therapy works. And we know about the classical CBT model, where emotions, thoughts, and behaviors interact. That's the three-way triangle. But in terms of functional disorders, it's five-way, which includes the physical symptoms and also the life stuff. And there are several manuals available, like the one shown here, for CBT for practitioners to use, or if we need to refer to the child to a CBT practitioner, then that's also done. There are plenty of CBT practitioners. So when we discuss the diagnosis, and there are several terms we use. Sometimes we use the term the hardware software approach, saying like, your hardware is all okay, but it is a software problem. It is a disorder of neurological function. Some of my colleagues tend to use the mind body overload description in order to address it. Now, once you have addressed this, once you deliver a diagnosis, you have to wait. You have to leave it to the family and the child, and to see whether they accept it or not. And like I said, you have to have that buy-in before you do. But although we talk about hardware and software, the brain doesn't separate these things into neurology and psychiatry circuits. And in fact, most of these brain networks are at the intersection of this motor control and processing your emotion, your cognition. So these are all integrative networks, including the salience network. So it's very important for functional disorder. So adult colleagues are probably more familiar with these works by David Perez from Mass General, who had done some pioneering work on neuroimaging in functional disorders in adults. So this was a result from 23 women. And what they have showed is, the gray matter volume of the left anterior insula is reduced. And when you then map the history of childhood trauma, it seems the same thing is there. So the magnitude of childhood abuse mapped onto the same area of the left anterior insula. So seems to suggest that with the history of childhood trauma and the functional disorders, there seem to be a bit of overlap in terms of the volume of the left anterior insula. But bear in mind that it's very important to say at this point that the history of trauma may not always be there, particularly in children. Particularly, history of trauma, including physical and sexual abuse, etc. I personally haven't come across any child with a functional disorder who we have proven a precipitating factor as experience of trauma. But I understand that in the adult population, it is pretty common. So Perez and colleagues, David Perez and colleagues have also then further done connectivity, looked at connectivity, functional connectivity and information flow, and they have shown that there are further connections from the left anterior insula to the right anterior insula to the temporoparietal junction, etc. So and to areas of motor control related to symptom severity. So what these connectivity studies highlight is that all these networks seem to be involved in these individuals with functional disorders. And they also looked at how childhood trauma burden relate to the functional architecture in those population, and how that would be different from psychiatric controls. And what they have shown in this paper is, I think this was the first study to look at this sort of connectivity, was the magnitude of physical abuse burden related to how closely the amygdala and the insula were connected to the precentral gyrus, meaning the more physical abuse, there was more connectivity strength between those brain areas. Now, although this could sound very exciting in terms of the neuroimaging connections, and finally we identified the network circuit which causes functional and neurological disorder. These are all studies. The neuroimaging studies are in its infancy when it comes to functional movement disorders. The reason is we still haven't identified the proper controls, because we all know that the medications and other conditions will also affect these networks. So in summary, if you want to look at a framework for understanding the pathophysiology of functional neurological disorder, you could say that there is impaired functioning in several brain circuits, and which leads to disruption in the cognition and the physiological processes. And particularly, the 5 domains, which includes emotion, processing, including salience, the agency, then attention, then interoception. So these are all important, and predictive processing, etc. So these multimodal networks, they all interact. And if you look at an individual patient's symptom, it can be characterized as a totality of all these impairments in these severe networks. So it is essentially a multi-network disorder, and with involving abnormalities within and across these brain circuits. It's very important. Like agency, for example, agency is a very key thing, because agency means an individual's conviction that they are the ones responsible for their actions or thoughts. So, which means that a feeling of having control or a free choice, which is a defining aspect of movement. So the individual must possess the perception of intentionally initiating the movement. Secondly, the movement has to align with the intended will. And what happens in people with functional neurological disorder, that this is impaired. So even though it is done voluntarily, as far as the individual is concerned, it is involuntary. And similar to agency, another problem is with attention, for example. Now, again, these disruptions will characterize as attentional perseveration. So tendency to focus on a particular physiological system to the neglect of another system, and volitionally shift that attention to one organ or one body system. So these are all important, and all these factors, say emotion processing, emotional dysregulation, these are all interact together to affect these network circuits. And that's the current framework for understanding functional neurological disorder. How do you then, so the adult colleagues, and in the DSM-5, the term functional disorder is used, and we all now have moved towards using the term functional neurological disorder. But at least there are some colleagues, like for example, Dr. Paddy Gretton-Smith from Sydney, and colleagues, they have argued that perhaps functional is not the right word for this condition. It is at least some authors tend to believe that perhaps psychogenic is more an apt term than functional. But there are arguments for and against these two models, because the model, the argument for this being labeled as psychogenic is that the symptoms are powerfully determined by psychological conditioning, and consistent with a referral to psychology or psychiatry. And also that shows that it is lack of organic disease. But the argument against functional is that the term should actually be dysfunctional and not functional. And also functional disorder then also creates that ambiguity about absence of neurologic disease. But this argument perhaps is still going on, whether functional versus psychogenic is the right term. Perhaps we can have a discussion about that as well. And what is the prognosis in pediatric functional disorders? Like I said, we always start the very beginning itself. Once the diagnosis is delivered, that yes, your symptoms and signs are in keeping with what we call a functional neurological disorder, or a disorder of neurological function. And we often also give a good news message, which is saying that in most cases we have seen that things will improve with treatment. Now, again, the opinions might vary on whether that is the right approach or not. Also, in our practice, what we also important to highlight to the child and the family is that there is a possibility that the symptoms will get worse before it gets better. Now, the reason is, it's very important that sometimes there will be an avoidance exacerbation of symptoms. Like, for example, the child tries to stand to try and walk, and then collapses, and then is afraid to then walk because of fear of collapsing. Is afraid to do something because of the symptoms might exacerbate, and that might then perpetuate. So we often tend to say that in the beginning, when the treatment is started, your symptoms can get worse before it gets better. And there are very few studies which have looked at the actual prognosis. And though some of those studies have been with non-epileptic seizures. And interestingly, in the remission rates have been quite high, like 43 to 81% in studies, small studies. In fact, there are no studies even in adult population, I believe, with over n equals 100. Now, this was a small study in 15 to 50 patients, and the remission rates have been 43 to 81. There was another study by Annie et al. In a 1-year follow-up study in 147 children with non-epileptic attacks and motor symptoms. 75 to 100% had improved symptoms. Another 3-year follow-up study of 15 children, 12 had substantially improved, and only the remaining 3 had severe disability. So these are the very few prognostic studies, but in general, it seems that when it comes to functional movement disorders in children, the prognosis seems to be relatively better compared to adult population. And people have obviously been interested in what might be the prognostic factors which would correlate with bad outcome. And now this data is very, very sketchy, because there is some published data which suggests that the longer you have the symptoms before diagnosis, the prognosis tends to be bad. But again, that's not our experience. And to be honest, I don't think there is much data out there. But what we know is, like, if there is a pre-morbid psychiatric problems or conduct problems, then sometimes the prognosis tends to be bad. And also the comorbid neurologic disease, whether it affects the prognosis or not. For example, if a child has seizures, then does that affect the prognosis of the non-epileptic attacks? There is some literature to suggest either way. So whether some papers suggesting that comorbid neurologic disease suggests that correlates with a bad outcome, and some other papers showing the opposite. So if we want to sum like what we have discussed today, like, the diagnosis, we know that the DSM-5 has moved, and it's important that the ruling in the positive signs is important for the diagnosis. And as we have said in the very beginning, the Freudian idea of focusing on the etiology has moved, and now we prioritize the mechanisms, not the etiology. So the precise mechanics of how a particular functional motor symptom arises is was not a concern before. Previously, the emphasis has always been on the hypothesized stressors and psychological factors, which sometimes we still tend to do that. Like, there is a tendency to be a bit biased and always think that, oh, there must be some bullying going on at school, or there must be some exam stress, etc., which might be the sole reason. But the focus has now moved on from the psychiatric concept, or focusing on that etiology, to why this is happening. And that's very important. And that's where the biopsychosocial framework comes. So, and then we know about the increasing neuroimaging and other evidence on the brain circuits, and how we can mediate and modulate this genetic epigenetic information. So these are all important. The treatment, we know, again, biopsychosocial, the role of physical therapy is very, very key in functional motor disorders in children. So is occupational therapy, and there are consensus guidelines now, I believe, on speech and language therapy as well. And lastly, the stigma is very important, because there is still an ongoing public stigma against this motor functional neurological disorders, and we as physicians are also partly to blame for it. And often in our non-verbal communication with colleagues, or be it nursing staff or administrative staff, we are also unconsciously party to propagating this stigma around the motor functional disorders. And the problem is, once the patients identify the stigma, they tend to internalize this, and internalization then promote feeling of vulnerability, helplessness, hopelessness, frustration, anger, and which then will stand in the way of getting them back on track. So it's very important that that we all take care. Like for example, we all have done this. So what is this diagnosis? Or what is then when the functional disorder child comes into the clinic? When the nurses identify that it's a functional disorder, then often the statement that it's functional, or it's a psychosocial. So we are all guilty of that, and that's very important, and that's something which we all have to, as clinicians, try and address. So because by doing that, motor functional disorder or functional movement disorders is an ideal condition where there is an artificial divide between physical health and mental health, and that is very pervasive in our society. And addressing functional movement disorders, which sits in that divide, is extremely useful to bridge that. So back to the question of, is functional movement disorders, should we be referring them to the neurology clinic or to the psychiatrist clinic? I think as the paradigm has shifted and more evidence is coming out, then it looks like this is more, it could very well sit within the neurologist realm. And again, I'll be interested to see the views of our adult colleagues. But unfortunately, loads have happened in the adult world. They have got a society of their own, a functional neurological disorder society. Fantastic books have been published. In the last 10 years, amazing developments have happened, but unfortunately, the pediatric world has not kept up with it. And I think there is a huge unmet need when it comes to addressing functional movement disorders, because even when you look at the literature, there seems to be a very clear difference in how these two populations are addressed. And unfortunately, currently, there is a huge unmet need in terms of what's the best way of treating these children. And I would be very interested in hearing the views of our colleagues today. I'll probably stop there now.
Thank you so much, Professor Biju. So it was amazing, actually, listening on functional movement disorder, the repertoire, the diagnosis part, the clinical element to it, and also psychogenic versus functional, which will be really a point to debate. And also touching upon the management part really very well, because that is something where we really struggle and feel frustrated about. So it's other than the family, it's also the treating team, which, is really frustrated. So let's get on to the experts one by one. And Professor Hassan, I can say, has listed out 3 questions. So I would say we can go directly to Professor Hassan first. Sir, please go ahead and ask your questions. Yes.
Thank you, Dr. Akana. Dr. Biju, I really enjoyed your excellent presentation. You clearly outlined the functional movement disorders in adults as well as in the pediatric parts. I really enjoyed your excellent videos. All of them are information. I really enjoyed that. I think we overestimated or underestimated the cases of functional movement disorders in pediatric side. We are putting these all cases in the non-epileptic paroxysmal phenomenon. So when we look at our chapters or the files, the kids, what is the diagnosis on the non-epileptic paroxysmal phenomena, we will find a lot of cases with functional movement disorders. So are you agree with me about this comment?
Yeah, yes, particularly the common functional disorders that we see in clinic are the gait, the functional children with can't walk, won't walk, functional gait, and the tremor. But I agree. Often the true non-epileptic attacks or the psychogenic seizures, they're also quite common, and that's where the children then get extensively investigated, and rightly so, because video EEG is now considered standard to make that diagnosis of paroxysmal non-epileptic. But again, answering your question, it's true. Like when it comes to a jerk, or when it comes to any paroxysmal movement, often the thinking is like, is this epilepsy or not? And the real focus on, like, could this be an organic, or could this be a functional movement disorder, is not there. And I suppose, common things happen more commonly, and the important in terms of exclusion, in terms of like treating, I suppose you want to exclude epilepsy, like there was a question of level of myoclonic jerk, like, was it SSPE and those sort of things, like, you see a myoclonic jerk and you wouldn't straight away assume that this is a functional myoclonic jerk. You really want to rule out the epilepsy, don't you? So from that point of view, in terms of ruling out treatable conditions, perhaps that approach is right, as opposed to thinking about epilepsy.
Thank you. Dr. Akana, if I have a time, I would like to express my too bad experience about the functional movement disorders. Then we diagnose about the organic etiology, visual. If I have time,
sure. If it's
just
like
only two
few
minutes.
Yes.
Yeah,
yes.
okay, thank you very much. One of them is we diagnosed dystonia 1 month ago. We hesitated to put the diagnosis of organic etiology or genetic etiology. Then, but we started the medication, but kids has some clue about the functional movement disorder, functional dystonia. She was in the pediatric surgery department. We consulted them, but when we entered our departments, we did a full neurological examination. We did several video analyses and an EEG examination. Then the kids, we extended the neuroimaging studies. We did spinal MRI examination. The kid has a lesion in the spinal area. So we think it is a spinal tumor, but we did a tissue biopsy revealed that spinal abscesses. This is my recent experience. We initially thought that this is the functional dystonia, but the final diagnosis is in an infection disorders, spinal abscesses. The second one is that 2 weeks ago, I hesitated to put the diagnosis of non-kinogenic dyskinesis, and then we did several EEG examination. There is no clear evidence about the epilepsy. Then we put another diagnosis, functional dystonia, might be, and then we did a genetic testing. Genetic testing revealed a kind of variant. This is the non-kinogenic paroxysmal dyskinesis. So then we did a semiologic analysis. Then we asked, is there any stimulation to trigger the non-kinogenic paroxysmal dyskinesis? We identified the kid has extensively used caffeine. So, and then her variant is related to KCNM MA1 mutation. Then the diagnosis was the genetic-based paroxysmal dyskinesis. This is my recent two bad experience. One of them comes from the genetic test, and the other one's when we use the spinal neuroimaging studies. This is why I gave this two bad experience during the last 2 months.
Thank you so much for sharing those. And I'm sure all of us have these experiences, because the workup is so much expensive, expanding, and tiring, that at times, by the time you really label them as functional, it's really extensive workup. So thank you so much for sharing those.
Thank you,
I
Dr.
would
Khan.
move on to Dr. Sanjay Pandey for his comments and his experience.
No, so the diagnosis is made incorrect. That is absolutely important in functional neurological disorder, that unless until you have not ruled out organicity, diagnosis of functional should not be made. And many times the diagnosis is straightforward, but sometimes diagnosis is challenging. Like if you see a functional seizure patient and there is a brain atrophy on MRI, you start thinking that maybe the seizure may not be functional, or there can be overlap, like 20% patients may have overlap of organic and functional disorder. So it's very important. And if you see the current NHS guideline, that says that functional neurological disorder diagnosis should be made by a neurologist. The reason it has been emphasized that we don't miss the organicity. So that is step one, that the diagnosis of functional should come from a neurologist, not from a psychiatrist, or not from a clinical psychologist, or not from the physiotherapist. Once the diagnosis is made by a neurologist, the step two is to have a intervention. And before the intervention, you should have a diagnosis, and you should convince the patient with the diagnosis. Once the patient is convinced, it's easy to treat. If you don't convince the patient with the diagnosis, patient will keep on hovering here and there, and they will keep on chasing different doctors. The basic problem in functional neurological disorder happens that you have a diagnosis, but you are not able to convince your patient. And that happens in our setup because of lack of time, that we don't have time for so much encounter. But it's very important to engage your residents, your fellows, and give some time. And if you don't have time, you can maybe admit your patient. Sometimes I do like that I admit my patient. And once I admit my patient, I have some time to look at them and talk with them and take the help of your clinical psychologist colleague. Because what happens that once you encounter the patient in functional disorder, many times the patient doesn't give the history in the first go, unless until you have made a rapport with the patient. Once the rapport is made, then the patient, you can ask the patient to write. Sometimes patient is not comfortable saying something, but maybe writing. So once the patient writes, maybe you can ask the patient to go back and come back with writing their complaint. And then you have a rapport with the patient, and then you can start working with your clinical psychologist, and then the process of counseling works. If you just straight away say that, look, you are functional, I have seen very senior clinician making a diagnosis of functional, sharing the videos, making a joke of the patient, making fun of the patient, and that will never work. Those patients will never come back to you, and those patients are never going to get benefited. So make a positive diagnosis, don't make a negative diagnosis. Once a diagnosis, convince the patient. Once the patient is convinced, take the help of your clinical psychologist, and if there is a psychiatric comorbidity, take the help of the psychiatrist, and then treat the patient. This is the way the functional neurological disorder patients should be treated.
Absolutely, Dr. Sanjay. Look, very, very, very. Those are the key points. Absolutely. We've had patients who were admitted and then with a movement disorder, and then spent several weeks in the ward with therapy and physical therapy and everything. And at the time of day of discharge, the parents turn around and ask, like, so that's all fine. Like, thank doctor, she's much improved. Now, what about the fact that like she can't remember anything, which was there in the very beginning, that she had lost her memory, but we never addressed it because in the original history that wasn't taken at all. So sometimes like other symptoms like pain, cognitive issues, etc., only will come to light later. So if only like much time is spent, a little bit time is spent taking a proper history, we wouldn't have to deal with it afterwards. And your point on like stigma is very important. We all make fun of. We all, I know, even among colleagues or with nursing staff or with administrative staff, we are guilty of taking things lightly when it comes to functional disorders. But the huge impact on quality of life for these children, like some studies have shown, like average number of days missed school is more than like nearly 28 days in some studies. And then average number of days off work for the parents goes into like several days as well. So huge impact on quality of life. So it's not something which has to be taken lightly. But I just wanted to ask your opinion on the new DSM criteria, because the new DSM criteria does not make it mandatory to exclude, to make it a diagnosis of exclusion. It is a ruling in diagnosis. But as pediatric neurologists, we are all guilty of imaging and LPing and doing all these investigations, including genetic tests for our children, before making a diagnosis of functional disorder.
No, the DSM-5 criteria says two very good things about DSM-5 criteria is, like you said, the positive diagnosis. The positive diagnosis means why the tremor is functional. The tremor is functional because it can be entrained. The tremor is functional because it is variable. The tremor is functional because you can distract the tremor. So if you can show those features, the tremor is likely to be functional. The second point about the DSM-5 criteria is that they have excluded the psychiatric comorbidities. Like previously, if you see the FAN criteria, then psychiatric comorbidity was a very important part of the diagnosis of functional neurological disorder. But DSM-5 has excluded that. Psychiatric comorbidities are no longer required to make a diagnosis of functional. Once you make a diagnosis of functional, you can say at the end, the patient has a psychiatric comorbidity or patient doesn't have a psychiatric comorbidity. But that is not the part of the criteria to make a diagnosis. These are two good things about DSM-5, and this is very helpful in the diagnosis.
Also, there is no need to prove malingering as well. We don't.
Yeah.
Yep. I would move to Dr. Tajul for his comments and his experience on this.
Thank you, Dr. Biju, for a fantastic, fabulous talk. Even it is close to midnight, I'm still awake, so thanks to you for that. So allow me with two comments and two probably questions. My personal approach would be, I've experienced bad experiences when approaching the patients with gunshot, approach, telling them up front, look, this is functional, this is psychogenic, this is something like in between. Your child wants to do it or does not want to do it. The brain has got control, but brain doesn't have control. So, and then the patient never turns up back again. They're lost for follow-up. So after years of doing that and losing patients, I've toned down a bit, probably I'll break the diagnosis in the second or third interview or clinic consult. But the first thing I emphasize to them, there's a high chance that this is not life-threatening and this is not going to hurt your child. So let's see how it goes from there. So this is my first. My second comment is I'm usually reminding my colleagues, my junior colleagues, my trainees, not to have a knee-jerk response and referring a child to a mental health facility or to a psychiatrist. I'm biased, guilty of that. But I feel that there's many ways of doing it, because the stigmatization is enormous. Once we refer a child to a psychiatric workup, even though it's turns out to be nothing, they're doctors like us, they are not aliens, from outer space, but still, the stigma, So that's my second reminder. Okay, now for a burning question, something very simple, but I've not able to answer that myself. do you have any thoughts about, my first question, do you have any thoughts about the exact mechanism that may explain the sex predilection in these functional or psychogenic movement disorders? You know, we know most of them are, you know, girls and 4-1, 5-1, different papers and different experiences. Mine is about somewhere between 3 to 4-1. So I would like your what do you call, valuable thoughts on that. The second more interesting or rather confusing question comment would be, now, as you have mentioned about agency, you know, I've always thought about that. I've always been confused about that. Now, there is physiological evidence, there is pathophysiological evidence that motor control pathway is involved in functional or psychogenic movement disorders. It is involved. However, most of the patients that we see, they claim, or rather they profess, that they can't control this. The motor control pathway is involved. It is activated. The prefrontal cortices or temporoparietal region is activated, but they confess, they have no control over it. Now, what are your thoughts about, you know, the thin line between involvement of voluntary control pathways, meaning that the brain is able to control it. However, the sense of control, or rather the sense of intention to control, is absent, because with the presence of sense of intention to control, that would veer us towards malingering or, you know, enacting an act. But this is absence of sense of intention to control. So what are your thoughts about it?
The genetics is interesting because, you know, when I was preparing, you know, I started looking at the literature this morning, and it struck me as well, like, you know, the genetics and the epigenetics and how these mechanisms. The problem is there isn't any data. Even the work from David Perez and colleagues, on the network circuits, they're all still small studies, but it's a good change. But we still don't know, basically, because even in these network studies, there are no proper controls as such, because these networks are affected by the medications that these patients are on, by their other comorbid diagnosis, etc. So, you know, there is a need. And also, I don't know how far we would be able to rely on neuroimaging and other circuitry in terms of precision medicine for these children, because there's a lot of heterogeneity in terms of the neuroimaging and circuitry findings in these children. So, you know, even transcranial magnetic stimulation, etc., have all been tried in adults, but I don't think in the pediatric age group thing. So the answer to your first question, I don't think there is. We know, although genetic epigenetic factors have been mentioned in some literature. The agency, I find it very, very fascinating, because you know, when you perform a movement, you get sensory feedback. You get a feedback, and you experience lots of sensory experiences related to the movement. And if that feedback aligns with the feed forward, then there's a causation and self-agency. But if that's impaired, then the patient, I don't know, I don't think the patient believes that it is a voluntary thing. And there's also the perception that, you know, how you generate your belief or explanation as to cause and effect occurring within our body. And that must be strongly influenced by expectations as well, which is why, like, sometimes you can suggest things to patients and things improve things. I don't know, like, perhaps that's where the psychology and the psychiatry comes in, you know. But I know, I'm pretty convinced that these patients do not believe that they are doing it. It is happening voluntarily. Of course, it has to happen voluntarily, but they don't believe it is happening, because the other opposite would be malingering or feigning. Now, in the last 30 years, I haven't come across any malingering, any feigning episode. I have seen malingering from a parent, but never from a teenager. who is putting it on. So, and I would be very, very, very reluctant to make a diagnosis of malingering or feigning because it's so rare. In children, it is very, very rare, feigning. So I don't know. I mean, there is some complex interaction with all these agencies, domains, which must be the reason. And ultimately, everything is like feeding into the sensory and the pre-motor and premotor cortex. But who knows?
Let me be the devil's advocate again. Now, with the concept of, walking through the concept of being unaware or, impaired self-agency itself, how would you put in, more in a humorous note, being possessed? Patients do ask, us, do you think she's being possessed? So knowing and not knowing of what you are doing, but you are executing that motor function through a motor relay. Your comments?
True. I think I read somewhere like, the idea that the management is changing. Management is based on converting the unknown unknowns to the known unknowns. Like Donald Rumsfeld or some has said in the past. Changing.
Right.
So
Thank you.
I mean, the key point is like we don't have answers to all these questions, and we don't even have a proper special interest group for functional disorders in children.
So I would connect to Dr. Charulata Sakla. She is an adult expert to our team. Dr. Charu, for the final words and your comment and your experience, please.
Actually, yeah, it's a bit late in the
I'm
night. So I
sorry,
just want to make the
apologies,
comments
apologies.
that the functional movement disorders, I think, are equally seen in children as well as adult. I work with Dr. Rajesh Udani also, so I have a certain amount of pediatric movement disorders that I do see. The stressors are different in the pediatric group. They're usually exams, they're usually some school issues or picking on them, children picking on them, or some kind of a childhood neglect or an abuse. These are the stresses. Whereas in adults, they are different. And there is another point that I want to emphasize is that the overlap between organic and functional disorder. In our cohort of patients in Parkinson's disease, we see 30% of the functional symptoms. And whether it's to draw the attention of the caregiver or it's to get the attention, we are not able to figure out, but it's as high as 30%. Second thing, Dr. Tahir mentioned about having missed the functional organic disorder, and then it turned out to be initially calling it a functional disorder, and then Dr. Hassan calling, and then it turned out to be organic disorder. This has happened to the best of us, and we've had these dilemmas because I had a functional movement disorder patient who was from a religious community, and this religious community is very sort of strict with their behavior and the laws. It's a Jain community where these people are secluded and they are living by very difficult standards. And this man had a clear-cut functional disorder, but when somebody had done his whole exome sequencing and he came positive for a heterozygous Wilson's disease. Now, it becomes very difficult when something like this comes up, when you are sure that it's a functional disorder. During your workup, one of the tests comes positive. So I think ultimately the clinical diagnosis is what is very important. As Dr. Pandey said, the entrainment, distractibility, going into the details. And I do admit the patients as well. And treating a functional movement disorders, I feel, is very rewarding because they get better majority of the times. So I think functional movement disorders are challenging, but they're very rewarding once they get better. There are some patients who don't get better. Chronicity adds to it. Constant trigger factor adds to their issues. And inability to deal with the trigger factors, particularly in the children and adults, is what causes the problem, I feel. And it's a very complex topic, and sometimes the line between the organic disorder and functional disorder, I feel, blurs. And it becomes very difficult for the clinician sometimes to take a call as to whether they are dealing with how much is organic and how much is functional. So these are the problems that we face while treating the functional movement disorders.
Well, thank you so much for those really pearls of wisdom. And I would now go back to Dr. Shefali, ma'am, for final winding up of the session. Yes. Yes.
I thanks Dr. Biju for an excellent talk, and that's why you have only one question, and that person also asking whether that myoclonic jerk patient was SSPE. Dr. Biju, that myoclonic jerk patient.
No, that was published video, and from
Okay,
according
so
to
you
the
don't-
authors, no, it was
Yeah.
yeah.
No, I'm just saying it
Of
was
course,
so
but
perfect.
as Dr. Hassan was saying, like, you know, if you see in like, you know, if you were practicing in India or Turkey, for example, you would probably want to exclude things like that.
Yeah,
Absolutely.
I understand. And Dr. Hassan, like you said, even I remember I have missed one Perthes disease from a colleague's, some relative's patient. We were diagnosed as functional. Yes, you have to have a high index of suspicion. Yes, but always keep that chronicity in mind. I agree with what all of you have said. I know it's become late because we generally go till 9:30. I know it's near midnight for you, Dr. Tajul. But just one take-home message from everyone for just take-home message from all of you. I actually always the speaker gets the last to speak because he has to tell something in the end. So, Dr. Hassan, your take-home message, not only for Turkey, for everyone. Take-home message. Dr. Hassan, your
Yeah.
take-home message. Yeah.
Yeah. Comment about today's session. I
Yes.
really enjoyed. When I get message, I checked my files, and then I think we missed the diagnosis of functional movement disorders. Biju clearly outlined, and I'm really happy to be involved this meeting today. Thank you so much, Dr. Shefali. I think after that we will see we identify more cases in the pediatric side from the functional movement disorders. Thank you so much.
Yeah, thank you. Thank you. Dr. Taj, I know it's near midnight, please.
Thank you, Dr. Biju, for an excellent talk. I've always wanted to give a talk on functional movement disorders, but never really had the guts to do it because I think I didn't understand that very well. Anyway, so my take-home message would be, I mean, again, I appreciate phenomenology a lot, and I find that functional movement disorders may adopt any phenomenology. You know, there's no phenomenology which is what you call possessive of a functional movement disorder itself, one. Second, my approach to a functional movement disorder will be neither inclusionary nor exclusionary. I think we should take the middle path, you know, rather than being biased towards any one of those, and then see how it leads us to. Thank you.
To Charulata.
I guess she's left possibly. So
No, I'm here. Can you repeat the question? I just moved away from the computer.
Your take-home message.
So the take-home message is, again, I find functional movement disorders very rewarding to treat. And usually most of them do tend to get better with a good amount of counseling and good amount of positive suggestions. We never give them a negative feedback as to what is going on with their movement disorders or any other symptoms. We usually always encourage them. If they have any trigger factors, we try and sort them out. And that is where the key to treating the functional movement disorders are. You need to train your physiotherapists, you need to train your fellows, you need to train your residents, and you need to train your psychologists also towards this. A lot of psychiatrists sometimes deny that the patient has a functional disorder because they are seeing very violent movements and they don't want to take the onus of missing something organic. So I've had sometimes the problem in convincing the psychiatrists that it is definitely a functional disorder, whether it's a functional seizure disorder or it's a functional movement disorder. So that is another thing. And the overlap between the clinical the organic disease, like for example, I gave you Parkinson's disease, who have 30% of the functional symptoms. So that becomes a little difficult to segregate. Seizures with pseudo seizures, patients who already have seizures are also getting pseudo seizures. Again, those patients are a little difficult to treat because they already have the organic disease, and you're trying to segregate the organic from the functional. And the third thing is erroneous abnormal laboratory test, which a lot of other doctors harp onto the patient's mind that it is abnormal and that's why they're not functional. They have something organic. And this is exactly where I feel that we find the most difficulty in convincing the patient. And sometimes the patient doesn't get convinced with whatever you're telling him. They tend to go from pillar to post, and they go to different doctors. But then eventually, after a few months, the same patient turns around and comes back to you and kind of accepts, because they also need a let out to their symptoms. Very often I realize that the functional disorder patients, functional movement disorder patients, or functional neurological disorder patients also need an outlet to sort of get a release from their symptoms. And eventually they accept that it's a functional disorder. And eventually they come back to you and say that, look, I accept, and I'm willing to accept the therapy. So that is the take-home message that I want to give. And you should be very clear to the patient. You should be clear in your mind that it's a functional neurological disorder. If you're not clear, and if you have a doubt, and if you express a doubt about any clinical testing, or if you tell them that, okay, you have functional neurological disorder, but I still want to do the test to kind of confirm, that creates a dilemma in the patient's mind. So finish up all your tests, finish up whatever doubts you have in your mind, clarify your mind about the diagnosis, and then approach the patient saying that, look, you have a functional neurological disorder. I normally give the example of hardware and software, and that is how it works, that your hardware is good. That means your brain is all right, but there's something wrong with the programming. There's something wrong with the software. And that is how you tend to explain why it is happening to the patient. I also work with Dr. Hallett, who was actually quite a prominent person in the functional, and he had very keen interest in the functional movement disorders. And he Sanjay and I both were there at NIH with him. Sanjay was there for a longer time. I was there for a shorter time. And he's the one who created the empathy about these disorders in our mind and how to deal with them. And I never shunned to treat the functional movement disorders. I actually like treating the functional movement disorders because you get them better. Majority of them get better. So it's a rewarding disorder to treat.
Thank you for the very practical tips from your long experience. Thanks a lot. Mahesh, you want to add something?
No, I had a question to Dr. Biju. For kids who are very small, is there any role for placebos or placebo?
Oh, that's a whole field. It's a so complicated field. Taj will also agree the effect of placebo and nocebo and the ethics behind it in treating functional disorders. I think there are lots of practitioners who use placebo depending on what type of setting they practice in. In the setting that we practice, I don't think it would be acceptable. But it's a huge minefield area in terms of placebo. I'm glad that you brought it up, but it's I know perhaps I know in India, I don't know in elsewhere, it is still used, and even when you use into modalities like TMS, some of the results can be attributed to the placebo effect.
Thank you. Thank you.
Thank you. Rachna?
I guess we had a full-on session and super packed, and we heard from experts and everyone. So thank you so much. It was
No,
very-
Dr. Biju has to give a take home if you are not adding something, Rachna. If you're not
Yes.
adding, then Dr. Biju gives the final one. But one thing is for pediatrics, Yeah.
I think some points have been said. I think I
No,
suppose
once again, before you were coming to you, I was saying one thing that, for Dr. Charulata, you must be, you were handling pediatrics also. I think for pediatrics, more difficult than the child. Sometimes it's handling the parents because they just have this inbuilt in their mind that the child has an organic problem. So sometimes, Dr. Biju, what that placebo you were saying, we tried in some of them, and something like Benelgis was a vitamin, and was a very bitter one of the thing, So I mean, I've tried some of the patients coming from some village and all who really feel right to counsel after counseling sessions. Not now. I mean, in the past we have tried in the past, and it does work. I mean, it's debatable. Yes, now it's becoming less with more counseling and all that, and we're trying to understand what's causing the child. But we have been using in some patients coming from far villages and all. I mean, in the past, so that's why Mahesh asked, because we have used sometimes and some from some people who are not understanding at all for some time, not for long, but like for letting them to come for 1 or 2 more sessions after counseling, then we take them off. I mean, so it's important the parental counseling becomes, and obviously with empathy one has to handle I mean their situation, and the more complex comes when you have organic plus psychogenic part combined. So it is really very confusing and how to handle. So now it's over to you, Dr. Biju. I know we are very much beyond time. Yeah.
I think placebo is a holy grail of functional movement disorder.
No, I've said only in a very few, like, somebody from village who really feels ki nahi hai, and they're running and running from, some state coming from 700 kilometers. So in that case, that's why I was telling that Benelgis was a very bitter tasting one. So that one.
And I worked with Professor Jankovic in movement disorders, and he used to use saline to treat the functional dystonias, and he used to say that's Botox, and he didn't say exactly that's Botox, but he used to do that, and he got criticized, but he continued doing that, and many of the patients were convinced that they received Botox for the cervical dystonia, functional cervical dystonia.
No, this one we've just used in
They got
1
better.
or 2, No, we have just used in 1 or 2 who really not understanding for some time. Yes, they're coming from villages and all like that.
It's
not
the
routinely.
placebo effect is there in the organic disorders not organic, I'm saying in our disorders as well. If we give a pill to the patient and say you're going to get better, that's a very positive reinforcement. So that placebo effect is there in every pill and every trial that we undergo. In fact, in DBS also, we had a placebo effect, and in deep brain stimulation surgery, we had sham surgeries and DBS, and we had a placebo effect also. So those who didn't get the surgery had felt that, oh, they have not got the appropriate treatment and they didn't do well. So I think placebo
Yeah,
effect.
that's why we don't do that. We do a sham. So that's when TMS, we have they all are getting it. They don't know that they're getting the TMS or they're getting the sham for
Yeah.
it.
Yeah.
Dr. Biju, your final word before we call it.
Everything has been said. I suppose only just 2 short things. One is functional neurological disorders are real medical conditions, and they require a very comprehensive, multidisciplinary, and compassionate care. And early diagnosis, multidisciplinary approach will make all the difference. The second thing is, sadly, the pediatric neurology world is lagging far behind the adult neurology community in terms of functional neurological disorder. And I think this is the right time for organizations like the AOCN and the ICNA come together. Taj, this is for you as well. Yeah, I think this is good time that we step up and increase the tempo. I think we are lagging behind, and we are using models which have been tried in the adult population, and they're not the same. I know
Dr.
that.
Biju, we can do that. No, as an offshoot of this, Rachna is also there, Mahesh. They both are there for this SIG. We can just take it forward. Then we can have a collaboration and take it forward. We have all the leaders here. We have the adult leaders also on board now. So, I mean, if they are agreeable, so we can move it forward into another SIG of working, a sub-SIG of functional movement disorders. Yeah. Thank you, Dr. Charulata. Anyway, we all are also leaving. Thank you so much.
There are still 52 attendees.
64 in all.
64. Yeah. So there are still plenty of people interested in functional movement disorders. So.
Yeah, and we'll send them out. All of them we'll send out who wants to be a member of the SIG. We'll send a mail out. And I think I'm telling Mahesh and Rachna to take the lead, right, Rachna?
Yes.
Dr. Biju, you can have your final word. Yeah, please. Yeah.
That's it. I've said fantastic. It was a
Okay,
good session.
thank you. Thank you, everyone. Thank you, everyone. And Dr. Taj, I know it's past midnight. Thank you so much for joining
Thank you,
from
Dr. Biju.
Malaysia.
Good night. Good one.
Thank you, Dr.
Right.
Biju. Thank you, Dr. Hassan. Thank you, Dr.
Thank
Taj.
you. Bye-bye.
Thank you.
Nice to see
Thank you
you.
so much. Thank
Okay,
you.
great.
Bye.
Thank
Bye.
you.
Right.
Bye-bye.
Bye.
Bye-bye.
Bye.
Good night. Good night.
Good night.